Good morning, everyone. I'll start with today's case presentation. This case is of a 48-year-old male who is a clerk by occupation and hails from Rewari, Rajasthan. He came with chief complaints of pain in the upper abdomen on and off for the last 1 month following a open cholecystectomy and intermittent jaundice for 1 month following this procedure. Coming to the history of the present illness, on the 3rd of September, patient had an episode of pain in the right upper part of the abdomen and the epigastric region. This pain was insidious in onset. Gradually, it progressed. It was moderate to severe in intensity. The pain was non-radiating in nature, and at this point of time, the patient had multiple episodes of vomiting containing whatever food that the patient had ingested the previous day. For that, the patient took some over-the-counter medications in the form of antacids and antiemetics and analgesics. And the pain subsided, following which the patient went back to his hometown. And there he consulted a physician following an absolutely similar episodes of pain abdomen and vomiting 3 days later. The physician then advised the patient to undergo a battery of blood investigations along with an ultrasound abdomen. The ultrasound abdomen report will follow. And at that point of time, the patient was told that he has some jaundice and he has some mild jaundice. And the ultrasound that was done was suggestive of a perforated gallbladder, for which the patient was given injectable antibiotics and analgesics. However, the patient did not improve symptomatically, and the patient was advised to undergo further evaluation in the form of a contrast enhanced CT abdomen. So, talking about the investigations that the patient underwent, the initial one is the ultrasound report, which showed cholelithiasis with features of cholecystitis with contracted gallbladder and minimal pericholecystic fluid, and which was suggestive of a gallbladder perforation. At the same time, there was so the USG was suggestive of omentum paniculitis and omental addition or omental infarction. Then, since the patient, as we spoke about, did not these symptoms did not resolve, he underwent a CECT. The CECT report was suggestive of cholelithiasis with cholecystitis with pericholecystic anterior perihepatic and subdiaphragmatic collection, and adjacent omental thickening and adjacent suggestive of gallbladder perforation. And there was the calculi was around 9 mm and mural thickening of 7 mm. So then after this, the patient then consulted a surgeon who advised the patient to undergo an open cholecystectomy on 17/9/2023 following these investigations. The surgery, the intraoperative findings were not available, but whatever we have discussed with the patient, the surgery was uneventful. There was a single drain placed uh, in the right upper abdomen, probably in the subhepatic space. The drain stayed for 10 days. Initially, the output was purulent, which then evolved into a serous fluid. However, during the course of the drain placed, there was no bile noticed in the drain. Intraoperative findings and the biopsy report are unavailable. Patient following the surgery remained asymptomatic for a period of 1 month. However, after that, the patient started developing dull pain abdomen, which was more in the right upper quadrant, associated with yellowish discoloration of sclera, high colored urine, malaise, loss of appetite, and loss of weight, which was unquantified. So, owing to these above symptoms, the patient visited the operating surgeon and was advised a USG, which was done on 27/11/23, which was suggestive of choledocholithiasis post cholecystectomy status. He was then referred to a medical gastroenterologist to undergo ERC and clearance of the CBD stones. So ERC was attempted the next day, which is 28/11/23, and which showed the papilla, which was large, bulky, with nodular mucosa without ulceration, with extension proximally into D1, D2 junction, query, proliferative ampullary lesion, query neoplastic, and biopsy was taken, which was negative for dysplasia. So these are the images available of the UGI scopy, where it shows a lesion around the ampulla, exophytic, proliferative, with specks of blood noted, and the biopsy was taken. The biopsy showed increased number of intraepithelial lymphocytes, which is 40 to 50 lymphocyte per 100 epithelial cell. The villus architecture is within normal limits, no villus blunting. The epithelium matures normally to the surface, so there's no dysplasia, and the biopsy was termed negative for dysplasia. And in the comment, they had mentioned that it may be suggestive of celiac disease, but the patient had no prior symptomatology. So, along with this, there is no history of fever with chills, abdominal distension, upper abdomen fullness, melena, hematemesis, or any altered bowel habits. Coming to the past history, patient does not have any medical comorbidities, no other surgical history, personal history, consumed a mixed diet, no habits, bowel habit is regular, and there is no contributory family history. Summarizing the case, so a 48-year-old gentleman referred to Mahatma Gandhi with the periampullary mass with intermittent jaundice and dull aching epigastric pain for 1 month associated with loss of appetite and loss of weight following a surgical procedure of open cholecystectomy for acute cholecystitis or a gallbladder perforation around 2.5 months back. Coming,
Go back to your first slide. Yeah, so here it's not clear from this that when the cholecystectomy was done. So it would be better to say that pain in the upper abdomen, and I think the pain is in the right upper abdomen.
Yes.
So you should say pain in right upper abdomen and jaundice for 1 month following an open cholecystectomy, which was performed 3 months ago. So both the things should come here. Next.
right.
So from this history, the pre-cholecystectomy history, go to the pre-cholecystectomy. Yes. It should be clear from your description whether you are talking of a biliary colic or acute cholecystitis. So you have not mentioned whether there was any history of fever.
So there was
because pain and vomiting can be there in biliary colic also. So what differentiates the biliary colic from acute cholecystitis is fever in the history and the duration. Any pain which lasts more than a few hours, 4 hours, 6 hours, 8 hours, is more likely to be acute cholecystitis rather than biliary colic. Biliary colic would settle either on its own or with medication over a period of few hours. So that is important.
right.
And then go to the next. At some stage, you use the word that findings are suggestive of cholecystitis. Whenever you use the term cholecystitis, or whenever you say pancreatitis, you have to always qualify acute or chronic. Acute cholecystitis is a clinical and radiological diagnosis, whereas chronic cholecystitis is a pathological diagnosis. You cannot say chronic cholecystitis based on history or imaging findings, except that if you see a contracted gallbladder, thick-walled gallbladder, you might say that it is a consequence of chronic cholecystitis. But typically speaking, chronic cholecystitis is a pathological diagnosis. So many students say that his history is suggestive of chronic cholecystitis. That is not correct. History is suggestive of cholelithiasis, which then results in chronic cholecystitis. Now, in the CT report, because you said that he had jaundice before cholecystectomy, but in the CT report, you did not tell us anything in relation to jaundice. Whenever patient has jaundice on ultrasound as well as on CT or MR, whatever investigation you have done, you have to tell us whether there is intrahepatic biliary radical dilatation. If the CVD is dilated, what is the extent of dilatation, which will tell you the level of block. So that is important.
Right.
Now, when you said that his cholecystectomy is done at that time, you should again recapitulate and say that cholecystectomy done on day whatever of the onset of pain, because from now it looks like as if this was an episode of acute cholecystitis. Everything is suggestive of acute cholecystitis. So the cholecystectomy was done on day what of acute cholecystitis?
Sir, after 2 weeks.
2 weeks. Because that is important when we discuss the timing of cholecystectomy in acute cholecystitis. This is probably the worst time to do. cholecystectomy. So you from your here you should have said cholecystectomy done on 17th, which is day 14 of the onset of his pain. And then after cholecystectomy, yeah, they have made a diagnosis of choledocholitis. Does his history fit in with the diagnosis of choledocholitis post cholecystectomy?
So they can be always missed stone at the initial.
Does his history?
No, sir.
I asked you a point blank question.
No, his history does not coincide.
The history of continuous dull right upper abdominal pain, loss of appetite, loss of weight is not the classical. The classical presentation of choledocholitis, whether pre or post cholecystectomy, is again biliary colic with or without jaundice, with or without high grade fever, chills and rigors. If that is not there, then the history is not. Although they have seen a stone in the CVD, so you should have on your own said that although it was seen and he was referred for ERC, but I don't think that his history is suggestive of choledocholitis. Okay,
right, sir. Coming to the general examination.
Rajan.
Yeah, we need to relook at that histopathology because you're saying there's infiltration of lymphocytes.
Yes, sir.
Have they done any special staining for looking whether they are monoclonal or polyclonal?
No, sir, they haven't, sir. The only histopathology, following the histopathology, they were just referred to us over here, sir. They have not done any follow-up work on the biopsy report, sir.
Because it's interesting, because they are lymphocytes. One possibility, if they have diagnosed celiac, which can result in obstruction, is a duodenal lymphoma or
yes, sir. Duodenal adenoma.
Yeah, duodenal adenoma, because it's not a duodenal adenoma. Duodenal adenoma would not have a lymphocytic infiltration. If there's a lymphocytic infiltration, maltoma should be certainly considered in the diagnosis. That is an important thing to consider.
Yes.
Though it's a very rare presentation, but histopathology is there, so we have to interpret.
Yeah, Dr. Desai is right, because if you look at the endoscopy picture also, it shows nodularity, but the mucosa looks apparently normal. So a submucosal nodular lesion is again a situation where you should suspect lymphoma. Young patient with history highly suggestive of malignancy. Endoscopy shows normal mucosa. CT scan shows diffuse thickening of a viscous stomach, small bowel or colon, circumferential thickening, and repeated biopsies are negative. Repeated superficial mucosal biopsies are negative. All these points should raise a suspicion of a lymphoma.
So can I move ahead?
Yeah.
Coming to general examination, the patient on examination was conscious oriented, moderately built and nourished. BMI was 23.2 kg per meter square, ECOG 0. Maintained a pulse of around 90 per minute with a BP of around 138-78 mm of mercury. In the right arm supine position, afebrile at the time of examination, and comfortable on room air with a breath holding time of about 26 seconds. No icterus, no pedal edema, no pallor, no supraclavicular lymphadenopathy or any other lymph nodes in the or generalized lymphadenopathy. And on oral examination, the patient appeared well hydrated and there were no other mucosal lesions.
So since we considered a possibility of lymphoma, it would be better to say no cervical, axillary, inguinal, which shows that you have examined all these areas.
Coming to the abdominal inspection, so the abdominal appeared flat, the umbilicus was central, there was a right subcostal incision of open cholecystectomy, well healed, no impulse on cuffing over the incision site, no visible upper abdominal lump, no visible peristalsis pulsations, no scar marks, scratch marks. Hernial orifices appeared to be normal, renal angles normal, and spine on visual inspection appeared to be normal. Coming to palpation, the abdomen was soft, non-tender, no palpable lump in the upper abdomen or epigastric region, no hepatosplenomegaly, no other palpable mass was noted in the abdomen. Percussion, the liver span was 14 centimeter in the mid-clavicular line on the right side, and no free fluid could be elicited clinically, and auscultation, normal bowel sounds were heard. And digital per rectal examination was also unremarkable with the finger staining of yellow colored stool.
Rather than only saying unremarkable, you should say what you were looking for and you didn't find. What were you looking for?
Sir, on the examining finger, if
Finger is later. First is the finger inside.
yes, so any masses, sir, if any
So
blemish shall
say on rectal examination, no recto male patient, na?
yes, sir.
No rectovesical
Vesicle
nodule,
nodules.
no extra
Yes, sir.
rectal nodule palpable, and
Yes, sir.
finger stall reveals normal colored stool with no melena.
Yes, sir.
May I interrupt, sir?
Yes, yes.
An important thing is you should always look for occult gallbladder cancer because the history is suggestive of gallbladder cancer because it's a very common presentation of gallbladder cancer. Though we don't have a histopathological proof, it could have missed biopsying the place where the malignancy was present. For example, if they've taken a biopsy, they've not found any break in the mucosa, they would have taken a random biopsy of the gallbladder. And I don't think follow-up biopsies have been done.
Yeah, I was actually going to ask that once he finishes that suppose you ignore the post-cholecystectomy investigations.
Yes.
Based on his history, anything else in the examination? No.
No, sir.
Yeah. So based on the history, what is your assessment?
Sir, a middle-aged male presented
I
with
didn't ask you whether he's middle-aged, male or female. I asked you what is your assessment? Give me your assessment.
sir with regards to his symptomatology, right upper quadrant pain.
Don't repeat what you have already said.
Look, sir, it's difficult to say a gallbladder malignancy with this history at this point of time.
So cholecystectomy done
Yes, sir.
within how much? 3 months.
Yes, sir.
3 months, patient comes with pain, loss of appetite, loss of weight, and jaundice.
Yes, sir.
What is the possibility?
Sir, the history is suggestive of definitely there may be a possibility of a missed gallbladder malignancy.
That is what Dr. Desai is
Yes,
saying.
sir.
This is the presentation of a
Yes.
missed, whether gallbladder histology was done or not done.
Yes.
Even if it was done and it shows chronic cholecystitis, still it could be a missed malignancy.
Yes.
Because as we all know, when a gallbladder is subjected to histopathology, the pathologist takes only 3 sections: fundus, body, and neck. So it is possible that a malignancy is missed by a cursory examination. But this history doesn't fit in with the ultrasound diagnosis of cholelocholithiasis.
Yes, sir.
This history is typical of a missed gallbladder cancer. That is what Dr. Desai is pointing.
Yes.
What are the provisional diagnosis? One is
One is a missed gallbladder malignancy, sir. Then, based on all the investigations that have been done, a periampullary lesion, which may be, sir, based on history, mixed gallbladder malignancy, choledocholithiasis.
Why do you think of
Based on history, sir, the patient has had the history of gallstones. There was, and then he underwent cholecystectomy. There's always a chance that there may be a missed stone in the CBD, which may have presented later. But there is no corroborative history of typical the patient had loss of weight, loss of appetite. They don't really fit in with the symptoms, with the history of CBD stone.
patient comes with a post-cholecystectomy and jaundice?
Yes, sir.
You first think of a CBD stone. You first think of
Biliary. Yes, sir. So bile duct injury can also be considered, sir, as a third differential.
Third, the patient comes with a post-cholecystectomy status with jaundice.
Yes, sir.
What is the first provisional?
Sir, bile duct injury.
Now the thing against bile duct injury is that against not exactly,
Exactly.
but supporting other diagnoses is anorexia and weight loss.
Yes, sir.
So which is saying maybe question mark
Malignancy.
There's still nothing which is still supporting the diagnosis full double.
So post cholecystectomy jaundice, commonest cause you are right is choledocholithiasis.
Yes.
It could be a bile duct injury and biliary stricture. It could be a missed gallbladder cancer. It could be a missed another biliary or pancreatic cancer, because we know that even in cholangiocarcinoma, there is an associated higher incidence of gallstones. So at that time, gallstones were symptomatic, cholecystectomy done, and the malignancy, so unrelated malignancy can also be there. Then you have to discuss. So choledocholitis, as we discussed earlier, the classical presentation is biliary colic, intermittent. You said he has intermittent.
He has history of
So that is the
intermittent
point
jaundice.
in favor of a choledocholitis.
Yes.
He has intermittent
Intermittent
jaundice.
jaundice.
Yes.
Malignancy. Yes, exactly. That's why.
If the history is truly correct that it is intermittent jaundice, then it is difficult to explain it by a missed
Yes,
gallbladder.
actually, sir, when we will look at the blood investigations, also his bilirubin is also it is not persistently high. There are incidences of absolutely normal bilirubin as well, sir.
Currently, in your general examination, is he having jaundice?
No icterus currently.
That is
You haven't
important.
told. You have told in your history. You haven't told the currently behind is not jaundice.
Sir, in systemic examination, general
But
examination,
you
I
should
mentioned, sir.
insisted currently behind is having no jaundice. Otherwise,
diagnosis of CAGB and post-mortem DBS both go out.
both got.
Yes.
Otherwise, CAGB, why CAGB produces jaundice? Because involvement of this ileum or the CHD, it will be a continuous, not an
So,
intermittent.
so should we mention anicteric in the history itself or in the
Still the patient had jaundice.
Currently,
He does not complete with jaundice.
yes, his complaint was that I had jaundice, now resolved intermittent. Currently, no.
So his presenting complaint is not jaundice, but the history of presenting complaint is jaundice.
Yes.
So presenting complaint is not jaundice.
So the CAGB and the DBS, both post-left coli and the post-open coli probably rule out.
Well, not rule out, less likely.
Or less likely on the basis of history and examination.
First origin would be before older coli.
And
Periambular.
we cannot ignore the endoscopy findings, because we have the picture which shows that there is something around the papilla, which doesn't look like a typical adenocarcinoma, because mucosa is normal, there is no ulceration. It is a submucosal lesion. Biopsy is negative, but biopsy shows excessive lymphocytes, which should not be there. So there is something happening around the papilla, which we don't know what it is.
Yeah, another important point I wanted to stress is you can have intermittent jaundice even in biliary injury because of recurrent inflammation and subsidence of that inflammation. It might be present only at the time of cholangitis, and it is still evolving biliary obstruction. It has not become a stricture yet, but it's an evolving biliary injury. And one thing we need to know is why the surgeon preferred to do an open cholecystectomy versus doing a laparoscopic cholecystectomy.
Sir, from what I discussed with the patient and the patient's family, the surgeon was of the opinion, since he was anticipating a difficult gallbladder, owing to the radiological assessment, he was more comfortable in doing an open cholecystectomy versus doing a laparoscopic surgery, sir, at his center. So he had counseled the patient beforehand, and there was no attempt of a laparoscopic cholecystectomy to start off with. The patient directly underwent a open cholecystectomy. So that is what was explained to the patient as well as his family, sir, prior to the surgery.
Yeah. So we have a difficult gallbladder, and a difficult gallbladder biliary injury is very common. And another thing to remember is that if you have acute cholecystitis, the incidence of CBD stone is as high as 25%. So it could still fit in with the picture.
Right. So can I move on?
Yeah.
So summarizing, 48-year-old male, referred case of periampullary mass, intermittent jaundice, dull aching abdominal pain for 1 month associated with loss of appetite, unquantified loss of weight, underwent open cholecystectomy for acute cholecystitis bar the GB perforation 2.5 months back. General examination is unremarkable, and abdominal examination only shows a well-healed scar of previous cholecystectomy, no other positive findings on abdominal examination. Coming to the summary of his blood investigations and the investigations that we did following the patient had come to our OP and then subsequent admission, sir. So this we will just quickly go through the investigations that were available. The patient does not have the complete set of printed investigations. These are all the investigations that were available, sir. So the initial investigations was done in September 23, was showing a total bilirubin of 1.5 with an OTPT of 64 and 48 with a raised alphos and GGT. On the 11th, sir, on the follow-up, there was a rise in the total bilirubin of 2.5 to 2.5 from 1.5, and the alphos was 209, sir. Then
whenever you are presenting this sequence or series of investigations, you have to mark the date of intervention. So you have to here mark when the cholecystectomy was done.
sir, it was done on 17th.
So then 11th is not post-op.
No, it is pre-op.
Pre-op.
17th is a
Yeah.
middle values.
Yes.
So just prior to surgery, these were the set of investigations that were done. That is 17-9, showing an HP of 12.9, normal counts, normal platelets, normal creat, and other investigations are also unremarkable. Then post-surgery,
So
sir.
you have to comment that even pre-cholecystectomy, his jaundice is intermittent.
Yes.
The biliary obstruction is intermittent.
Yes, sir. I was going to say that. So as we can see, sir, the jaundice is not progressive. It is intermittent in nature. And there are features of biliary obstruction in the form of raised alkaline phosphatase and raised DGT. Just prior to surgery, his lab values, including LFTs, have come back to normal. Post-surgery, as the patient said, for almost a month, the patient was doing well, a month and a half. Then, as the pain came back, patient started appearing icteric, and at that point of time, the total bilirubin was 3.6, direct being 2.4.
Don't read the number. Tell what you make out of it.
So at this point of time, there was again patient become icteric, and there were features suggestive of biliary obstruction.
That's all. Where is the evidence of biliary obstruction? What is the alkaline phosphatase?
Sorry, no, not biliary obstruction. Elevated alkaline phosphatase suggests of cholangitis, subclinical cholangitis. Enzymes are raised. I beg your pardon.
What Dr. Desai was saying, that even with biliary stricture, any benign biliary obstruction, whether it is stone, stricture, choledochal cyst, when you have cholangitis, you can have jaundice. And once the cholangitis settles either on its own or with treatment, the LFT improves. So this picture is suggestive of cholangitis. It would have been better if we had the hemogram also at this time showing elevated counts.
Yes. But even during this time, the patient says that he was never febrile.
It could be subclinical cholangitis.
Yes, subclinical cholangitis. And then following
subclinical cholangitis means patient doesn't give history of fever. But when you do investigations, you find bilirubin to be increasing. Enzymes are high. Alphos may also be high. You find counts to be high with polymorphonuclear increase, but the patient doesn't give history of fever.
Yes. Then following the next available investigations, the LFT, other than the alphos, has come back to normal. And then this is what the last set of investigations patient had come with. We have just repeated a hemogram here, sir. The patient is currently anicteric and comfortable, sir. We had done a triple phase CCT when we saw the patient in the OPD, and we had asked to get evaluated in the form of a triple phase. So it shows a post cholecystectomy status. There's an ill-defined heterogeneous area. Sir, I have the video. So the liver appears normal, sir. Sir, at the duodenum and the ampullary region here, sir, a mass can be seen here. It is a considerably large mass, sir, almost obliterating the lumen of the duodenum. And
is it a duodenal mass or a pancreatic head mass?
Sir, it is looks like a pancreatic head mass infiltrating into the duodenum.
Without this, can you say it is pancreatic head mass?
No, sir.
It is CT. You have to do the CT. You don't have to make your interpretation based on something else. Yeah. What is it?
Looks more like duodenum.
More predominantly duodenum, sir.
This is the duodenum. It looks like more like a circumferential wall than a duodenum.
Duodenum.
More on the medial aspect.
You don't say circumferential, it is protruding from the middle wall of the duodenum. You can see
it is more on the medial aspect. How only the peripheral part is through the area which is not thickened.
Yeah.
Otherwise, it is all rest of the area looks thickened.
no, it is filling the duodenal lumens. The rest we can see the lateral wall of the duodenum is a normal wall. Normal wall.
Yeah. So what did the radiologist feel about the CT?
Sir, ill-defined heterogeneous area measuring approximately 2.6 into 1 centimeter in the gallbladder fossa, region closely abutting the margins of segment 5 of liver, and mild soft tissue standing in adjacent pericholecystic fat, query post-op status, and focal area of soft tissue standing and thickening in omental region in right hypochondrium, closely abutting adjacent anterolateral abdominal wall in pericholecystic fat, closely abutting gastroduodenal region. In the right paracolic location, one of the largest, measuring 16 mm into 19 mm, query post-op, query neoplastic, mild prominence bilobar IHPR, hyperdense focus in distal lower end of CBD measuring 5 to 6 mm, likely calculus, sludge ball, and CBD measures 8 mm. Large lobulated enhancing mass lesion, approximately 3.2 into 3.4 into 4.9 centimeter in the proximal duodenum, in its ampullary periampullary region, arising from medial wall with intraluminal extension causing complete luminal occlusion, neoplastic. Small lymph nodes in the pancreaticoduodenal, gastrohepatic, aortocaval, and mesentery, one of the largest pancreaticoduodenal region measuring approximately 7 mm in the short axis. Fatty infiltration with relative hypertrophy of its chordatal.
So go back to the previous. So what are the paracolic they are describing mass? We didn't see that on the.
So in the initial CT scan, they suggested gallbladder perforation,
Yes.
gallbladder perforation with omental thickening of paniculitis.
Yeah, local paniculitis in the pericholecystic region. So right from the start, they have mentioned the same.
Maybe the sequel of this gallbladder perforation.
So again, this finding, either on CT or on an oral contrast study, if you see that there is a mass which is filling the entire lumen, but he doesn't have any symptoms of gastric outlet obstruction, this is again a point more in favor of a lymphoma rather than an adenocarcinoma. An adenocarcinoma, which is causing luminal obstruction on imaging, will usually be associated with symptoms. But lymphoma being a soft, so although it is filling the entire lumen, but still there is no mechanical obstruction.
Yes. So we had also gotten a PET CT done.
So what was the radiologist's diagnosis on CT? Those are the findings. What is their impression? Did they give a diagnosis?
No, sir.
They didn't.
They are
Okay.
So PET CT was done on 2nd of this month. It was suggestive of non to faintly FDG avid ill-defined elongated sheet-like lesion with SUV max of 3.9, measuring 3.8 into 1.1 centimeter with mild perilesional fatty standing noted in the GB fossa with hypodense changes in the adjacent part of segment 5 of liver. Query post-op, query residual GB, suggest further evaluation. No abnormal focal FDG uptake lesion in the rest of the liver parenchyma. Gallbladder post-cholecystectomy status. Low-grade FDG, avid and non-avid, ill-defined soft tissue density in perilesional fatty standing noted in the right supracholic omentum. 1.5 into 1.2 centimeter with SUV max of 2. Subserosal along the gastroduodenal junction. FDG, avid, soft tissue density, intraluminal lesion, SUV max 7. Measuring 3 into 3.7 into 3.6, noted in D1, D2 part of duodenum. The lesion is causing significant luminal compromise, no significant extraduodenal extension of the lesion noted. No abnormal metabolically active lesions anywhere else in the present studies. So this is the images of the PET CT. Here we can see that there is a light enhancing lesion, which is just
Why the image is looking so distorted? You have enlarged it in the wrong direction. If you pull in one side, then it gets distorted. Whenever you insert an image, you have to enlarge or compress it in from the angle.
One
If
direction.
you do it from the angle, it will get proportionately reduced. If you do it from the side, from one of the margins, then it will get distorted.
Here, sir, in the image of the PET scan, where we can see that there is take up in the proximal duodenum, almost obliterating the whole lumen, with a lumen visible on the lateral side of the duodenum. However, the medial wall, just adjacent to the periampullary region, all of it is obliterated with the mass, with a uniform SUV, with a uniform tracer take up in the duodenum. Also, there is some take up in the gallbladder fossa along the liver, sir. So these are the two positive findings that were noted on the PET.
No, what about the third one, the bottom image on the left side? What is that activity?
Lower motion.
Yes.
I think they have described it. Read the report, PET report. No? So that's a separate activity, this one.
What is that activity in the lowermost term, which is on the left side?
Yeah. Can you see this one?
This is chest, na, probably.
Hmm?
This is chest. Na.
हाँ,
Because of that,
हाँ, ये तो chest है. ठीक है, topic से भी कुछ.
Humerus, yeah, humeral.
हाँ, ये तो chest है. But what is it?
This is chest. लगा.
Paratracheal, left paratracheal. Have they described
it is
anything?
supraclavicular road.
No, sir.
Is it,
So chest
Which mention you can.
Hmm.
they have not mentioned it.
In the report, they haven't mentioned.
the video discussed?
No, it may be a lymph node, paratracheal lymph node,
Increase
which again,
the both of the lobes of thyroid gland. Yes, we have taken that.
So this is probably
Thyroiditis. Query thyroiditis.
because there is something, some uptake is there. So what was their impression? Have they given any diagnosis on PET CT? Just findings.
Yes, findings.
So I would agree with Rajen that there is a strong suspicion, and there are so many other findings also which suggest that it could be a lymphoma, which is totally unrelated to his first gallbladder problem and surgery. I think we should probably go for a two-cut
biopsy. Either.
Sir,
biopsy.
After discussion with the PET CT, the perilesional standing, they were saying that it may be query deposits.
No.
That standing that is showing some sort of a
Gallbladder had inflammation, GP perforation.
That's histological diagnosis. Rajan, what is your opinion overall?
Two possibilities, sir. Because of commonality, gallbladder carcinoma is still possible.
Okay.
But that lymphocytic infiltration into the duodenum and proliferative lesion without mucosal involvement makes me suspect lymphoma, but it's a very rare diagnosis.
Yes.
Gastric wall thickening is not there, so maltoma is also less likely. Pure duodenal maltoma is a case report. I can't make a clinical diagnosis of that. The only thing that makes me suspect that is the fact that there is infiltration of the lymphocytes.
Yes.
So greater than 25 lymphocyte
Injury-
infiltration
injury
is
remains.
very significant. It is almost 40 to 50. And also in these scenarios, there's always a possibility of, as sir said, maltoma, lymphoma, a type of lymphoma, any type of lymphoma, and also pancreatic.
One thing is, this is unlikely to be myeloma because Jordan does not have myeloma. Second thing, it is unlikely to be a carcinoma. Carcinoma does not have a normal mutation. Now we have only two provisional diagnoses which are most likely. One is this thing, lymphoma, and other thing can be a renal gland adenoma, which may have increased number of lymphocytes. But renal gland adenoma does never have it onto the periampullary. It is always onto the lateral wall of the duodenum, which is both renal gland. Now the third possibility is the rare thing which I am the flight of idea can be the tubercular.
It's a huge mass.
I'm saying that's what it's a flight of idea. I'm not saying it has any evidence.
Many things like if you are suspecting lymphoma, there's no lymph nodes other.
Yeah, actually, if they have seen 40, 50 lymphocytes, if it is tuberculosis, they should have seen something else also.
Maybe, but I think we need to have a tissue.
Yeah, we need to have a core needle biopsy.
Core needle. That's what I wanted to ask. It has to
biopsies, repeat biopsy.
You need to have a full thickness biopsy because it's not visual side. You don't need to worry about anything.
Yes.
You can have a good full thickness biopsy. And then second thing, after biopsy, you need to have also IHC. The earlier biopsy which we have, can they do some IHC markers ready to save?
Only hyperplasia was there on the cell hyperplasia, no dysplasia, even no dysplasia was there.
No dysplasia was seen. They have clearly mentioned, they have actually mentioned in the impression. There was a small line mentioned at the other page.
It was a superficial biopsy. No?
But sir, irrespective of that, we cannot just look over the fact that there are so many lymphocytes in the lesion.
To all the students in the audience, this point which Dr. Ajay is mentioning, sometimes a poorly differentiated lymphoma, poorly differentiated adenocarcinoma may look like a lymphoma on routine histology. So that is why whenever you have a suspicion of lymphoma, and if you are seeing a picture like poorly differentiated adenocarcinoma, you have to do immunohistochemistry, which will differentiate between an adenocarcinoma and lymphoma because the markers for the two are different. Second is that to diagnose a lymphoma, because lymphoma is a submucosal lesion, a superficial biopsy is not. Either you do a deep biopsy if the location of the tumor allows you to do it, or you do a core needle biopsy. Core needle biopsy can be either endoscopic, US guided preferably, or it can be trans-abdominal, transcutaneous. It is always better to have an endoscopic ultrasound guided transvisceral core needle biopsy. So in stomach and first or second part of duodenum, a core needle biopsy is possible, US guided. That would give you the tissue from inside the tumor. You see the tumor and you take it from the inside of the tumor rather than from the surface of the tumor. But short of that, if the endoscopist is experienced, comfortable, they can take a deep biopsy. Deep biopsy, either you use a larger punch or you do what is known as a biopsy on biopsy, a well biopsy. You take a biopsy at the same place, you take another biopsy, and you try to go deeper into the tissue. And as Dr. Ajay is mentioning, because it is on the medial wall, you don't have the risk of perforation. The only structure which is at risk is CBD, but that will be far away. So that risk is not there. It all depends on the angulation of the scope and the expertise of the endoscopist. And whenever you have a suspicion that it could be tuberculosis or lymphoma versus adenocarcinoma, it is very, very, very important to establish a tissue. Normally in a periampullary lesion, we don't insist on a tissue diagnosis. We try to get it, but even if we can't get it, we go and operate on radiology. But here, because the suspicion of adenocarcinoma is low, suspicion of lymphoma is high, it is very important to confirm, because if it turns out to be lymphoma or tuberculosis, the treatment is totally different. Then you are not going to operate. Then you are going to give either chemotherapy or anti-tubercular therapy. Yes, Rajan.
Yeah. Also, you need to tell us whether H. pylori was positive or negative, because that has an implication for maltoma. H. pylori would increase your risk of both adenocarcinoma and maltoma.
Yes.
98% of Indian population has
pylori. Yeah, that's true. What Ajay is saying, that prevalence of H. pylori is so high that it may just be a coexisting pathogen.
Yeah, but a negative report would help us.
Yes, yes.
Comments?
There is a question. Nabeen Podial. Nabeen, you are from Nepal, if I remember correctly. Can it be celiac disease associated lymphoma? Yeah, but I don't know whether it is possible to make a diagnosis of celiac disease without any history of any alteration of bowel symptoms, clinically at least. That is what Manmohan also observed. But I'm not sure about celiac disease associated lymphoma. Anybody? Rajan, you can give some more information. Naveen, if you know about it, just tell everybody. Put your microphone on.
Good morning.
Yeah.
Yes, Naveen.
Yeah, go on, Nabeen.
My concerns for this is because celiac disease has certain histological, like there is neutrophilic infiltration within the small bowel. So based on the background that the patient already had so much lymphocytic infiltration followed by surgery. So I felt like because the surgery might have given some sort of stress or some sort of trigger that might lead to lymphocytic transformation or something like that along that line that led to lymphoma, something like that. I was basically thinking about the histological background that we had, and then development of the subsequent pathology. So, so it's just my concern. Thank you, sir.
Yeah, you're right. That is what the pathologist also said, that because they have seen so many lymphocytes, they probably mentioned the possibility of celiac disease. But what I was saying, that since there was no history of alteration of bowel habits in the form of diarrhea, I'm not sure whether we can entertain that diagnosis.
And also the jejunum would be definitely involved because celiac disease mainly involves the jejunum.
Yes.
So we would have seen some kind of thickening or enhancement on CT contrast. So that is one thing that makes it less likely, but not impossible. But we are in the realm of case reports now. We are not in the realm of clinical diagnosis. We are basically relying on investigations to hint us in that direction.
Yes. So I think that is what the plan is. Dr. Anand is the consultant in charge, that we will try to get a tissue diagnosis with immunohistochemistry and then come back and report what we found.
Is it a syndrome with thyroid and paradiurnal any vein or something? Because thyroid can't be negated.
But if we are talking of MEN syndrome, then it will be a very brightly enhancing lesion, a neuroendocrine. And then I don't think neuroendocrine tumor will have such rich lymphocyte. So that's very important. I mean, normally in a duodenal mucosa, you should not be seeing lymphocytes. So
I'm just thinking of thyroid.
Yeah. We need to keep that in
I
mind.
also tried to do read on celiac disease associated hepatobiliary issues. So there have been a few case reports of hepatic malignancies, but there have not been any specific concerns about gallbladder malignancies. Although gallstones are more common in patients with celiac disease. So that is.
The thing is that on PET scan, I think the thyroid takes up PET.
Yes, sir. The thyroid will generally take up FDGs.
FDG. So it might be just a regular normal find.
Does it? I think it's brain and urinary bladder.
नहीं सो कुछ मेंशन मतलब ब्लैक किया नहीं मैंने साइड में अटैक होने के बाद भी उसको मेंशन नहीं किया जाता कुछ रिपोर्टिंग में.
So then we should know what are the organs which take up the normal PET scan.
Normal.
One servicing brain
and
urinary
bladder.
Brain, bladder, and cardiac shadow will get enhanced. These are the three areas which we know. But will thyroid will get enhanced in all? It get enhanced in few.
But you said they have mentioned possibility of
Thyroiditis, mild thyroiditis.
Because the uptake on two sides is different. Right is not taking that much. Left is more avid. So that is why it is a focal pathology. It's not a normal. Normal uptake should have been same on both sides.
Yes, sir. I stand corrected. Yeah.
Okay, I think we will close. Thank you very much. Thank you, everyone.
Thank you. Thank you, everyone.